So I think now it's 10:05. So we will start with the we will start with the opening session from our MC, and then I think a few more participants will join slowly. So I will hand over to today's MC, Gigi, so you can start.
Yes, okay. Thank you, Sin. Good morning and good afternoon. Welcome everyone to the first day of the version training course. I'm Thanaporn Sengjeotkul Aji, the coordinator of this training, and also your MC for today. So today we are going to begin with a video presentation named Yang Mi Duang Tawan. The video campaign on HIV/AIDS provided by TNP Plus AIDS Access Foundation. The meaning of Yang Mi Duang Tawan is the sun is still shining. So sit back, relax, and please enjoy.
เราคงรับคุณเข้าทำงานด้วยไม่ได้ทำไมล่ะครับคุณสมบัติของผมก็ตรงตามที่บริษัทกำหนดไว้ไม่ใช่เหรอครับ
นิดก็นึกว่าเราเข้าใจกัน
นัดเข้าใจนะว่าเราคบกันได้แต่งงานกันได้มีลูกกันได้
แล้วปัญหาของนัดคืออะไรอ่ะ
ปัญหาของนัดคือครอบครัวของนัดน่ะเขายังไม่เข้าใจพวกเรา
เอาไปคนละขวดเลย
ขอบคุณค่ะพวกพี่กำลังทำอะไรกันอยู่เหรอคะ
พี่รณรงค์เรื่องเอดส์กันอยู่ค่ะ
แล้วทำไมไม่เห็นมีใครสนใจพวกพี่เลยครับ
มันก็เป็นแบบนี้แหละแต่ว่าพวกพี่ไม่ยอมแพ้หรอกนะ
ให้พวกผมช่วยไหมครับรับรองมีคนสนใจพวกพี่ขึ้นแน่
แม้จะมีบางอย่างแตกต่างจากใครเขาไม่ได้แปลว่าชีวิตเราจะถึงทางตันยังมีดวงตะวันส่องแสงทุกวันเท่าเทียมกันทุกคนยกมือยืดอกกันหน่อยไล่ความเหงาหงอยกันไหมทำตัวเราให้แข็งแรงทั้งกายทั้งใจกันไว้พวกเราหนทางอีกไกลชีวิตยังได้อีกยาวยังมีดวงตะวันทุกเช้าไม่เห็นต้องถอดใจออกไปยืนมองฟ้าไปท้าลมฝนเราก็คงเหมือนกันออกไปเดินตามฝันที่เธอกับฉันเคยฝันกันไว้มีชีวิตก็ยังมีหวังทุกอย่างมันอยู่ที่ใจไม่มีคำว่าทำไม่ได้ถ้าหัวใจยังสู้สยาม
แต่รักษาได้จริงเหรอน้อง
จริงครับพี่ยิ่งรู้เร็ว
รักษาเร็ว ก็จะไม่ต้องป่วยครับ
HIV มีครอบครัวได้ มีลูกได้
มีลูกได้ แล้วลูกอะคะ เดี๋ยวนี้มียากินป้องกันค่ะ ลูกมีโอกาสติดเชื้อไม่ถึง 1%
ผมมีสภาวะเสี่ยง ผมควรจะทำไงดีครับ
ผมแนะนำนะครับ ให้พี่รีบไปตรวจเลือดนะครับ
เด็กแถวบ้านเล่นกัน คนทำงานด้วยกัน อย่างนี้ก็ไม่เสี่ยงติดเชื้อ
ถ้ามีคนอยากศึกษาข้อมูลเพิ่มเติมเนี่ย ให้โทรไปที่ 1663
อันนี้นะ
ใช่ ครับ ในนี้ก็จะมีรายละเอียดบอกไว้นะครับ
หนทางอีกไกลชีวิตยังได้อีกยาวก็ยังมีดวงตะวันทุกเช้าไม่เห็นต้องทอดใจออกไปยืนมองฟ้าไปท้าลมฝนเราก็คนเหมือนกันออกไปเดินตามฝันที่เธอกับฉันเคยฝันกันไว้มีชีวิตก็ยังมีหวังทุกอย่างมันอยู่ที่ใจไม่มีคำว่าทำไม่ได้ถ้าหัวใจยังสู้สยามไม่มีคำว่าทำไม่ได้ถ้าหัวใจยังสู้สยามแม้จะมีบางอย่างแตกต่างจากใครเขาไม่ได้แปลว่าชีวิตเราจะถึงทางตันยังมีดวงตะวันส่องแสงทุกวันเท่าเทียมกันทุกคน
Okay, thank you. This video is aimed to reduce stigma and discrimination against people living with HIV. As you see, the video try to show that people living with HIV can have family, can have children, and they can work with the same page with other people. We can live together, just open your mind. Another thing in the video is show to help encourage children to come out and join the campaign. So I think it's time, this time I will give a floor to Piniwat to make a wrap up from yesterday's session. So Piniwat, please.
Oh, good morning, everyone. Thank you, Subha. Thank you for the video. Since we have only 2 minutes ahead, so I think I will skip the wrap up, but to the next session that will allow our new speaker, our handsome speaker from Chiang Mai. See, you can see his smile. He's waiting right now in the early morning right now, so we'll have a time to talk with you. But anyway, if we have time, we can come back together, talk more about yesterday or even the video that you just seen yesterday. So I think it's better we'll start with Dr. Chanane, and then I think maybe Gigi can give a kind introduction to Dr. Chanane and then start. Thank you very much.
Okay, so now I would like to invite Dr. Chanane Wanapirak to present Module 6, Concept, Tools, Method of CQI and Process Management. Dr. Chanane is an associate professor working for Department of Obstetrics and Gynecology, Faculty of Medicine, Chiang Mai University. So please welcome and give a big hand to Dr. Chanane.
Okay, thank you, everyone. Good morning for everybody and our colleagues from, different time and place. Actually, for the presentation from the clip, I think maybe I need not to explain any of the content today because that clip. That video clip is explained very clearly about the QI, the QI, quality improvement. At first, nobody, interested in the activity that two people in the script try to present themselves. But after that, they have another campaign from the children. That means we can get the new outcome from the new technique or new process. So today, actually, I will talk about the basic quality tools to use in the quality improvement, but particularly in the S&D reduction issue. Okay, so can I share my slide? So you can see my slide. Hello.
Yes, we can see.
Okay. So the slide I will present today is a bit different from the one that I sent before this time, because I think something it is I changed something inside, but if you need the new one, I will send after my talk today. Okay, so today I will talk about the QI, the quality improvement, especially in the stigma and discrimination reduction. Okay, so I will speak a bit slowly because actually I am the survivor from the COVID infection, so I have some problem in my pulmonary, but don't worry, because my brain is still okay. My brain is still okay. So the scope of this module is about the quality improvement process. Okay, so that I will mention about the basic of the quality improvement process, like a 3P concept, or the review, or the root cause analysis. And then I will talk about how to get the improvement by the news is the abbreviation from the NEWS. So I will give you the detail later. And the second one is the patient journey map. And somehow we will talk about the driver diagram. And finally, if we get our problem and try to solve it, so maybe we need the process management. So the whole thing is about, in the module 5, it's all about here. So at first, this slide shows the goal of the management of the people living with the HIV. So we have 2 major groups in the HIV. The first group is already infected. That means the people living with the HIV. So this group of the people, they need access to the service, like a quick checkup, or early receive the medication, or self-care practice. So, and we need the organizing the good service system for them. And sometimes we have the problem, we have to solve the problem using the QI. And then one of the big problem in our world right now is the S&D reduction is the important driver. And the other group is right now they do not infected with the HIV. So we try to use the prevention mode. So these 2 groups is the majority of the story of the HIV. Right? So if we look at the bigger picture of the goal, we need to aim or point to the same direction in every level of function, such as high reliability and happy workplace. So this slide is to show somehow like the strategy of the Thai group for prevention about the HIV S&D reduction. So the whole of this story, we aim as to high performance or high value healthcare, and in particularly about the S&D issue, mainly point to the patient. So in the first one, like up here, patient center here. In this dimension, for example, the care is easily accessible and provided by staff that communicate well, demonstrate knowledge and technical proficiency, and take enough time to address the need of the client. So for the other things that maybe integrate to the patient centeredness is clinical effective. The care is effective in achieving individual outcome that matter to clients and system-wide outcome that matter to the payer and the community. So something like the high-value healthcare is the bigger aim for us. So for the S&D reduction, we can aim us to the patient-centeredness dimension, and in the meantime, we can make the effectiveness of the clinical outcome as well. Okay, so for when we need to improve the quality of the service, like service accessibility and stigma and discrimination reduction in the health facility. So in this example is the main point that we have this conference. So first of all, we have to identify our goal. I mean, if you have a group in your country, so we need to brainstorming and make the goal. Basically, ask the people or ask our team in this question, like the clinical outcome of HIV in your country or in your area right now is how about it? Okay, and the second thing is the importance of the stigma and discrimination. Is it the barrier of the patient to get into the system? And the third thing is, what is the current situation of the S&D in your hospital, in your area, or in your, that the area that you take part. Okay, so from this activity, you can know the basic problem of your area. So, and then if we can connect to the clinical outcome, like the clinical outcome indicators, so far like the percent of the first CD4 that is lower than 200, or the percentage of the retention after the 12 months in care, or percent of detectable viral load among patients on ART. Something like the clinical outcome, that means we aim us to the clinical effectiveness. But for the S&D, we aim us to the patient-centeredness point of view or the dimension. And these two things is correlate together. Okay, so for the basic of the, the process of the QI, we may use the quality cycle to create a QI continuously and then achieve our mission like this. Okay, here if we, as we know that the PDSA cycle or the quality cycle will make us to give the new knowledge or the new process to improve the quality of care or quality of our process, and then we can reach our mission or vision. In the meantime, we can assess our process that can reach or can achieve to the mission or vision or not. Okay, so in the process of QI, at a very first step, we should make a consensus of our purpose. So I will introduce about the 3D models. It's very, very simple and very usable in every level of the improvement side that we can use it. 3D could be used in every level in improvement side, like organization level, unit level, or the project level, even on the individual level. Okay, 3P concept emphasize that we need to understand the goal of everything we do or will do. And 3P concept is the easiest to review our work and can lead us to immediate improvement, not necessarily to wait for a long time or something like that. So for 3P, it means it consists of the purpose, process, and performance. So I will start with the two things first, the purpose and performance. So the purpose, that is, what are the goals of the organization if you use it in the organization level? But if you use it in the activity or the project or unit level, you can ask like, what is the purpose of the goal of the S&D reduction project in in your situation or in your area, something like that. Okay, so when we get the purpose by make a consensus in your team, and then we need to ask for the measurement, everything that we need to, to confirm that we can reach our purpose or not, we need the performance evaluation. In the easier way, we can use the indicator as well. So, and after you get for the performance or indicator, you have to check the goal, check that our goals and metric or measurement is consistent, is go together. It is the same thing that we have to go through it. Okay, so because the purpose and the performance need to, cross together. One is the purpose that we need to go to, and performance is evaluate us that we can reach that purpose or not. Sometimes we have a problem in set up our purpose. Okay, sometimes, not every time. Sometimes we have the problem in setting up the purpose. So here is some example to get the purpose in even in every 3P user. Okay, like we can check the mission, our mission, our organization mission, or our team mission. We can ask for the key customer and stakeholder. We can ask for the need and expectation of our key customer, and the requirement of the professional requirement, and the key quality issue. Okay, for example, like in the mission in this area or S&D reduction, if we aim our mission as the value-based healthcare, so we need to make it into the people-centered or people-centeredness, and at the same time we can get to the the clinical effectiveness, clinical outcome effectiveness as well. Okay, so for the second one, if we mention or if we aim to the people living with HIV, that's the key customer, and we can ask them or try to get their need and expectation. And then like in Thailand, we or even in this course, we try to make a S&D training to get the understanding and how to solve this problem. Okay, and the key quality issue for this is what is the driver, attitude, fear, knowledge, or environment that will give us the way to achieve our goal. Okay, if you get both of the purpose and the performance already, and then go to the process. Because the process is a lot of things to do, so we need to identify the key process. Identify the key process, and the key process is the process that will give us the purpose. Okay, so if you get into the key process, one thing have to we can use it for helping is that try to zoom out the whole process and then pick up the key process in the whole process. So I will give you in detail later. Okay, the checkpoint for the process that is it the key process or not? We can use the simple question like, is it the improved process or the new process? Because as we know, if you're doing something as the old fashion, so you will get the old fashion outcome. You cannot get the new outcome or the outcome that we need. Okay. So the second thing is the rationale for that process is what I mean. If we can use if what to clarify. Okay. And the third thing is like, is it get or achieve for the better goal or not by that process? Okay, So this is the checkpoint for the detect the key process. Okay. So after that, when we get the three P concept to clarify or to create our job, and then we go on to implement the process into our job. After that, we can measure of the performance evaluation, and then we found that it's not achieved as we need. So we can use the gap analysis. In this area, we can use it in performance gap analysis. Okay, and then this picture is show how to use the concept of the gap analysis, like the recommendation or standards up here, and then the current and actual practice of our job is about here. So it is in the gap here. So we use this gap and try to make it close together to the recommendation or to the standard that we need, and we decide the practice. Okay, because we have a lot of job to do, so sometimes we can get the design practice under or lower than the recommendation, and then we try to make it in action plan. After that, we can upscale our job to reach the recommendation or standard from this pattern of the gap analysis. So I will show you a example of in some area we use the gap analysis to solve the problem as well. Okay, and then when we use 3P integrate to the PDCA or PDSA cycle, it is the same thing but in different explanation. Like in the MBNQA, they use the DALI pattern or DALI, DALI, but in the Deming cycle they use the PDCA. So it's the same thing. So the same thing in the meaning. So in design here, we have the process to design because we have the purpose up here, and then we try to make a process design to achieve our purpose, and use that process that we design to deploy. The wording that they use is action, and after that we need to perform measurement or learning or checking, and then if it not reach our goal, so we can use that one to performance improvement or improve. And the QI is happen here. The QI is happen here. Okay. By the way, when we put up the purpose of our job or our project, we need another three word to integrate it with, because sometimes the context of different area, different country, different location, maybe it's different. So that means we cannot copy the purpose of one area to our area, because we have different contexts. So we can learn about their purpose, but we cannot copy and paste for us. So we need the context and we need the concept to create our purpose, and then go through the design or plan, do check act or design action, learning and improvement, and this cycle will circulate. Okay, and the QI is happening in this area in the improvement. Okay, so how to improve our job? We need to know the problem first, which that problem is obstruct our performance. Okay, and the second thing, if we know the obstacle or the one that obstruct our performance, we need to get the opportunity for improvement for that part. Okay, here is some tools in improvement. The first one is news, voice of customer, suggestion system, or patient journey maps. So I will go through these tools roughly. Okay, For example, in the S&D issue, like if you have the numbers of the seropositive clients, do not seek care or lost follow-up from your hospital. So that may cause the ineffective or poor clinical outcome, right? Okay, so we need to ask in our team that what is the cost for loss of follow-up? How do we know, or how do you know that is the cost? And are you sure that is the real cost for them, and why? Okay, so this three question we can use it even in the S&D issue. It's very useful for that. Okay, and if we need to clarify the real cost, we have one tools that we use it. We call root cause analysis. Root cause analysis, or RCA. In Thailand, before I go through the Thai style of the RCA, so I just mentioned about the root cause analysis a bit. Okay, RCA is a tool used to respond to the incident. In the S&D, we may use not adverse event, but as inappropriate event, and to prevent reincidence of that incident. Okay, by learning from the incident with a clearly structured, systematic approach. So that means we have to use the system analysis. Okay, and focus on the system, not on the individual operator, not on the individual. Okay, and there is a hypothesis that the adverse event or inappropriate event occurring and having a negative effect on the patient is a system failure, not the human failure, not in the human failure. Okay, and actually we need it into the focus on prevention, not blame and punishment. Okay, the aim of RCA is to find a possible turning point. The turning point, if we put on this, knowledge about the turning point, we can turn around it. We can turning it from the unsafe or inappropriate act to appropriate act. That means we can turn point of the outcome. Okay, and lead to the process improvement. System defend or reduce or stop the likelihood of the insecure incident. Okay, so in Thai, we commonly use Thai RCA. It's easy because the RCA itself, they have a lot of technique to clarify, but for in Thailand, we commonly use in a 5-step RCA. That's put it in the cartoon picture here. First of all, we need the story and timeline. Like if you lost follow-up, if you have the client lost follow-up from your hospital, you need their story. I mean, what is the problem that they get? We need the story and timeline. And the second thing, we need the potential change or the unsafe act or inappropriate act. Okay. In the meantime, we can listen to the staff that attend on that area, because sometimes they do not know themselves what they did for the client. Okay. And after that, we can check it up. Is it the policy problem, or in the individual problem, or in the unit level problem? Okay. And finally, we create the solution to get the how to prevent it, how to make it better, and how to detect it earlier, like that. Okay. So for story and timeline, potential change, and then I mentioned about the potential change a bit. In the potential change or turning point, the thing that we can use it for helping us to point out the turning point is writing the entire process flow may help you to identify, okay, or the review of literature can approach us to the point that we can make it better, okay, and after that we can turn the point that unsafe or inappropriate act to appropriate act. That means the thing that happened will not be happen in the future. Okay. Okay, and in general clinical practice, we use the care process for define like assessment, diagnosis, plan of care, and care delivery, and educate the patient, and then discharge from our setting. Okay, for S&D or stigma and discrimination reduction, we can use it in the process 1, process 2, process 3, process 4. Like the process 1 is like at the OPD, the process 2 at the in the pharmacist level, or whatever or wherever that process happen. So we can list it on process 1, 2, 3, 4 for it's up to the process that we give it to the patient or to our client. Okay, as a facilitator will process all the information, and then we summarize the systematic factor of each turning point, because sometimes we have more than one turning point that we can use it for. Okay, and then create the solution as I mentioned. Okay, when we design the system or when we will decide the new system or new process, need the creativity and use the human factor engineering to create. Okay, after we finish the RCA for root cause analysis already, if you need to know that one is the cause, the real cause, root cause or not, we can ask the simple question like if doing so will actually prevent problem or not. Okay, and the other question is that just like will it repeat or will it happen again or not, something like that. Okay, so after we get the problem and we use the RCA method to clarify, and then if we want to know that is the real cause or root cause or not, we use these two questions. Okay, and then in another way for get the improvement, we can use the opportunity for improvement by tools. The tool is like a new voice of customer, suggestion system, patient journey map, or driver concept. Okay, I will get through this technique. Okay, for the first one, the news technique is the abbreviation from NEWS. Okay, N is the need, abbreviated from the need of the experience and expectation of the patient. Okay, E is from the evidence and professional standard. Okay, so W is from West, and the finally the S is from the safety. Okay, this is we can use NEWS as for the opportunity for improvement. Okay, the second method or second tool is listening to voice of customer. In the S&D issue, sometimes we need the deep listening to identify the real problem of the client. Okay, so sometimes we can use the suggestion system, especially from our internal customer. I mean, like in our unit and our friends unit, we are the internal customer altogether. So we can ask them whether we have to change something or up level our service on some process. The very interesting method nowadays is the patient journey map. When the people they come to the hospital or to our unit, they have 3 levels of sense. The first thing is what we give to them. That means we doing for them. We do it for them. Okay. In the meantime, they have some thinking in their mind, some thinking. And in the depth, the most depth is the feeling. If we can get into the feeling of the patient, or at least we can get into their thinking, that we can get the opportunity for improvement, and our unit or our service will go to the customer focused excellent service in the future. Okay, this cartoon it's just because sometimes the patient journey is not so very sophisticated, because it's their life, okay. And what we saw in the hospital is just very some superficial part, not in their feeling or in their map. Okay, so we if we can use this patient journey map method, we can get in the feeling or the thinking of the price, so we can up level our service to be the better one. Okay. The last one is the driver diagram. Driver diagram is just like we can indicate it or explain it into the 3P concept as well, because the P purpose is up here in the left hand side. Okay, and the process is in the right hand side. In the middle is the driver, that currently that if we use this one or this driver, we can achieve our aim. Okay, so it is the same thing like the 3P concept, but we identify driver first, so we can guarantee ourselves that the aim will achieve in the time that we mentioned or we setting up. Okay, so like I will explain in like if we need to lose our weight like 5 kilos in 2 months, 5 kilos in 2 months. So in the yellow box here is the technique or is the process, but in this middle part it is the driver. The major driver or primary driver for lose our weight is have only 2 points. The first one is energy out. The second one is energy in. If you reduce the energy in and increase the energy out, okay, your weight will lose. Currently in 2 months we can lose our weight as we need. Okay, so that is the concept of the driver diagram. The same thing like if we need to reduce the stigma and reduction and discrimination reduction from the baseline to lower than that in let's say 3 months or 6 months or 1 year, you have to aim yourself here and then think about the driver that achieve to the aim, and then create the new idea in the process here. Okay, so that's the concept of the driver diagram, or you can put it in the table like your aim is, and driver 1, driver 2 intervention that we create, and then the KPI that will measure the intervention that put it into the aim or not. Okay, we can use either in the diagram or in the table form for the driver diagram. Okay, but initially they use the diagram, so most of the people get the diagram like this. But in reality, we can use it in the table form as well. Okay, so finally, if we get the problem, get the opportunity for improvement, so we have to use that problem to solve by our process, because the thing that we can change is not purpose, is not performance, but it is on the process, and we need the management of the process. Otherwise, we cannot reach our goal. Okay, so I will taking this time to explain something like about the process management. Okay, in the process management, because in our job we put on a lot of process, so if we need to find out the key process, as I mentioned before, we need to use the zoom out the whole our process. Like once the people or the patient come into the hospital, we have a lot of process give it to them until getting out from the hospital. So that means that is the meaning of the process zoom out. After that, we need to identify the key process, as I mentioned before, and then use the key process to zoom in. I mean, get into that key process, and then use that key process to manage. Use that key process to manage, and most important is the process design. And then from the design, we can use that design for implementation and monitoring. It's not difficult for us, but the design is a bit in 3 bullets. The design is most difficult one to get into the new outcome. Okay, for example, like when some people go to the hospital for some operation, so they have to assess, and then surgical care plan, consultation. They have to inform consent, and OR scheduling and setting up, and pre-op preparation. So in the green box here is the process, and this action is the process zoom out. If we need some area that if we want to reduce the risk or incident in the operation, so we have to zoom in the area of operation or area of the pre-operation preparation, because it may the cause of the incident in the operating room, something like that. Okay, and if we use this way to zoom out and then zoom in some area that we need, and then we use the technique for improve or to identify the opportunity for improvement, like lean patient safety, evidence-based process management for process requirement, and human health care or something like that. So, okay, in this list is the thing that we can use it for improve our quality, the opportunity for improvement of our process. Okay, in another way, we can use the abbreviation that I mentioned before, like news, to ask every box or every key process in key box that needs evidence or safety or waste. We need not to use the whole thing to some area or to specific area. We can use some of them. Okay. Again, if we use it in the S&D, we can use it like in the process. For clinical use, we can use it in the care process. way. But for the S&D, we can use it in the process 1, process 2, process 3. It's up to your situation, your process in your area or in your hospital. Okay, and then if we get the process number 2 is the key process for the problem that we mentioned. Okay, we have to zoom in that process and use that process to design the new things for improvement, and then we implement that process and monitor. Okay, if we can put the whole story into the thing that we have to solve, the thing will happen like this: the performance improvement, that means the quality improvement, and if we can improve it all the time, the CQI or continuous quality improvement will get the practice that when we compare with the other and like a benchmarking with the other, so we can get the best practice for that issue. So from the 3P, from the DALI or PDCA to QI, and from QI you can get into the best practice in that area, or in that in the problem that we need to solve. Okay. Something have to mention here is when we decide the process or redesign the process for improvement the quality, have to know that use the human factor engineering, because the human ourselves, we have the limitation. Like a matter of memory, easily to distract from our intention, and sometimes the brain play tricks on us and make mistake. Okay, so when we decide, we need to know the human limitation, and then we use the human factor engineering to apply, and then we get into the new process, or the way that we can achieve our new process and achieve the purpose that we set it up. Okay, so here is some of the example or experience. This is from Vietnam. Actually, this one take from the paper. In Vietnam, they have they use the quality improvement process like this. They identify the gap, and the gap can list down here like a first, second, third. This is the gap that they use the QI process to solve, and then put it on the PDCA or Plan Do Study Act PDSA cycle, and then mention about the concern. The concern is the point that they need to solve. Okay, and make it in the new intervention. The intervention is the new process. It's a new process, and then after that we can monitor it before and after your intervention. So this is the example from Vietnam experience. Okay, so I think in Thailand, like this course that we attend, we start from the training, because at first we found that many people in the healthcare setting do not understand about the stigma and discrimination issue. So we start from training, and then getting into the QI. From that problem, and we improve service quality by QI and indicate together from training to QI. So here is some example, like we ask every hospital in the group that attend the meeting or the training, that the pattern of S&D pattern of S&D. After training, they know which one is identified as a stigma or discrimination action. So pattern of the S&D in their hospital, they have to list it down here and then identify what is the cause using the root cause analysis to identify the cause of the problem, and then try to improve it by the QI improvement process. Okay, and this is a process owner and the sub process is the something add on. Okay, the majority is in the area to be addressed. I mean pattern of S&D in their hospital and the cause of that, and then the solution for solving that one is list down here. So the activity at very first step is what is the current situation. We have to know the baseline situation of the S&D in your hospital or in our hospital. Okay, and then might have caused the stigma issue in your hospital. Okay, that's a second row. Okay, and the third one is what is the goal? Okay, for this, I mean S&D, and then we try to get the new process to achieve this goal. Okay, here is some example that I got from the group. Okay, like they identify that pattern of S&D in their hospital is like a separate zone or separate specific clinic. That means the people can, feel that this is the cause that they do not feel comfortable to attend in this hospital. So, but in depth of the hospital people or the provider, they think about the one-stop service, and it is convenient, right, and reduce the service process. But in the patient themselves, they think another way because it seems like differentiate them or discriminate them from the others. So that is the cause. Okay, and you see this cause is may the root cause of in this area, but may not in the other area. Okay, so that means if we need to identify, we need to identify in our area because the context is different. The context is different. Okay, and the solution from this is explore the need of the providing service to clients. Okay, that means and then there's sub process just like to in-depth interview, in-depth listening to them or ask them or whatever to get how we can provide the service that they need. Okay, so and the other is the okay for the other example like make a last queue for dental work. I mean the people who living with the HIV and need the dental service, they put this queue in the last queue of the day. So that means in this pattern of the action or of the process may put them on the uncomfortable and leave the hospital or do not seek to this hospital for service as well. Okay, so this is another pattern of the example here. Okay, from the group, and then we summarize in the practice that consider discrimination in one meeting that I have attended there, like a last queue, mostly in the dental service or operating room, and ward zoning system or separation of equipment, and then using what when communicate with patient is the major practice that consider discrimination in one meeting that I attend. Okay, if we can conclude this, and then after that, we need to identify how to solve this problem, how to solve this problem, or this process has to change. What will change to be is up to the context and the root cause, and we can get to do that part. Okay, in the experience of Thai group, okay, after we work for years, okay, we know that the 4 major factors that cause S&D in HIV now is mentioned about the ignorance, and the root cause of ignorance is something like knowledge or whatever. Okay, the second thing is anxiety, fear of infection. Sometimes they know the knowledge is have enough, but still have something in their mind about conscious about the infection. Okay, and the third thing is socially stigmatized attitude. Okay, and the fourth thing is healthcare environment and setting. If we look down to this area, we have 4 major factors that will cause S&D in HIV. The first, second, and third one is mostly in the human, and the last one is the system. So if you are the people who will getting to solve the problem, you will see that the fourth one is easiest way to solve first, and then after that to play with the human, because in the human is a bit difficult than the system itself, but not too difficult to be achieved. Okay. Okay, so that is the whole of the module 5 for me today to contribute to our group. Okay, I will ask for like this. If you need me to to review your project or your work, you can use this system and then contact back for the group, and then they will send it to me. I will review for you, and then just keep it back or get it back to all of you. Okay, by email, because we need time. I need time, some time to review and make a comment for you. Okay, and I appreciate to do that. Okay. Okay, so any question and comments, we'll welcome. As I mentioned before, because I have some problem with my lung capacity right now, so.
Thank you, Dr. Chanane, for your speaking and presentation, and I don't know how to say, but just give you a big hug for recovering from the COVID. It's just quite shock news, but anyway, I'm glad that you're here. Okay, for the other colleagues from different country, right? Do you have any comments, any questions first? This is your time. Giving Ajahn Chanane for basic information, we have number of participants who participate in the training. They are from different time zones. I think from really early morning, like 3 o'clock in the morning until the afternoon. So it's like a kind of 12 hours period. So maybe a little bit delay. Do you have any questions?
Maybe some people just listening and then sleeping and then very difficult. Actually, yes, I hope to see, because in this area of topic, it's very difficult to explain through the I mean like online. But if we have to have the face-to-face or on-site, it may be, I mean, better than than online method. Okay.
Well, for you who stay away, you have any question? We can start with your first part, like the basic knowledge and understanding about quality improvement. If you have any questions and need Dr. Chanane to clarify, you can ask this question about basic knowledge and understanding.
Or later on, Dr. Niwat. Okay. So if any of colleague from, I mean, wherever, if they can make it in that job, like in the project or some project like that, and they need some comment or some review for me. So may I ask the team to pick up and then send it to me, and then I will review and give the comment back to them. That's maybe better, because in the quality improvement side, sometimes when we get into the lecture part, it's just like a very understanding, even very understanding. But when we put ourselves into the work, into the job, you will start from very early part. We'll start on. We cannot go through. So we need time. Or I know that our colleague need time to clarify and to setting up, and then try to make it in the very I mean when they get back to their job, their work, and then if they have some problem or some job that they need me to review for them, I feel happy to do for them. Okay. And give it back to give the comment back to them. Okay.
Yes, thank you. So we have two options right now. If you have like kind of urgent questions or comments, need clarification, you can do that, or later on you can write it down and then consult Dr. Chanane can give his comment later on through your email. Yes.
Okay, Pinua, do you hear me?
Yes, please, Gigi.
Yes, Mr. Uncle Ko raised his hand, so I think he has a question. Yes.
Okay.
Hello, can you hear me?
Yes, Lieutenant Ongkoko. Yes, please. We lose you again. Okay, Ongkoko, go ahead. Okay. Sometimes it's happened, like the lowering down of the speed of the internet from Myanmar. Ongkoko is a lieutenant, from the police department who interested in joining the S&D CQI training workshop. So I'm quite surprised and waiting for his question. Okay, Ongkoko, please come back. Okay.
Yeah.
Yes, of course. Sure. Go ahead.
Yeah. First of all, I would like to express my special thanks to
Ongkoko, we lose you. Another way around is, can you type it in the chat box?
Now I started understanding his strategy to teach us how to make a good. And I would like to ask him something, that is, if you don't mind, I would like to see his self-styled acronym.
Sorry, when when he start questioning, it's like he sing a song, so we didn't hear him clearly. So Uncle go. I think we lose him. But anyway, we can come back to him later on. So right now, I may need some help. I see Dr. Vino smiling again. From Sri Lanka. Dr. Vino, do you have any experience on working on QI, quality improvement, in your hospitals? Can you share, or you have any idea or example or questions? Please, Dr. Vino.
Yes, I am working in a hospital in a local set in Ministry of Health in Sri Lanka. There are many hospitals around the country, more than 300 hospitals. So STD clinics, the sexual health clinics are situated more than 40 hospitals. So I'm working one of the hospitals, and we sometimes admit the patient to the general wards, same with the other patients, same as the HIV patient. We don't have separate wards. We manage equally. And sometimes we found that healthcare setting, there are stigma and discrimination. We have conducted haphazardly the programs like stigma and discrimination reduction program, but there is no proper way of monitoring how much stigma is reduced and quality improvement. So I think today's lecture, thank you, Dr. Chiang, I have learned a lot how to improve the quality improvement process and development of indicators, the input process and the output. So those things I think I can implement in further in a small scale. Thank you very much.
Thank you. It's good to hear that. So it seems like you sparkling with the idea of measure or try to understand the situation. So from what I learned from Dr. Chanane presentation is about the check and the new improvement to act it, right? Okay. But anyway, at least we know your context, that in your context is about you didn't separate the client who come to the hospital, but you see the stigma and you try to reduce it, but you still need to improve the monitoring or checking up, and then you identify the problem to improve. Yes. Thank you, Dr. Vino. And see from Sri Lanka.
I have some comment for Dr. Vino. Thank you for your explanation. I mean, explain for us to understand your situation. So for the stigma and discrimination reduction, in my my understanding, we have two groups of the people in this area. One is the personnel ourselves. The other is the people or the society. Because the personnel S&D reduction, if you understand it, it's very difficult. But for the people or society, S&D reduction is more than the personnel. Something is up to the knowledge and attitude, right? So I think in Thailand, maybe in one of our staff in the course have mentioned already that maybe we can differentiate or divide to check it, like from the personnel ourselves, the reduction of the S&D reduction, and in the future we can put our effort onto the people or the society S&D reduction. Okay, that maybe it's easier for us to. Otherwise, we will feel really difficult to go through the problem. Okay, thank you.
Dr. Chanane, if I understand you, you mean like from Dr. Vino's examples, if we go into the hospitals and then we find that there's some stigmatized or stigma and discrimination in these hospitals, but trying to at least understand that there are two parts, right? The first one is the personnel, or you mean the healthcare staff, and the
Yeah.
other means the other clients or the societies who visit to the same hospital, right? And the first one really start with the personnel or the person in our team.
Yeah,
would be the first step. Yes. Okay.
Yes.
Thank
It's
you.
For my thinking is about if we can manage our part. Personnel, and then
Yes.
from our attitude, maybe it will give that environment to the whole thing. So that means we can put it on the people or society from the minimum part and then into in the future. Okay, because I don't think it's easy in the attitude, and knowledge is not so difficult, but for
Yes.
attitude is very, very difficult.
Yes.
But I
Dr.
think
Vino,
we can.
yes. Dr. Vino, what is your idea when with his recommendation?
Sorry, I couldn't hear properly. What is your question, please? Can you repeat?
Yes, it's about when I would like to know what is your opinion when Dr. Chanane mentioned that rather than without at least two part of that, and then the first good start is do investigation or try to do root cause in your personnel in your team first, rather than try to do both part in the hospitals and then for the others in the social societies and things like that. What is your opinion?
Yes, I think we have always case conferences there in Sri Lanka. Usually the pregnant mother, we received very recently the mother-to-child elimination WHO certificate to the Sri Lanka. So each and every pregnant mother who are HIV positive managed in hospital setting, we have conferences like case conferences. Even HIV positive cases, small scale, we get together the physician, nurses, infection control nurse, and everybody to give the best maximum cares. And sometimes we learn from the experience. Sometimes I remember some cases, the patients are complaining me, they felt some stigma and discrimination during their hospital stay. So I think we go back to the original ward, the people, the relevant authorities, and we discuss, and it's not like a learning exercise, not finding faults. We just learn in exercise, and we try to minimize the stigma and discrimination in Sri Lanka in that way. So I think the policy level, we also plan into some sort of S&D targets. We want to reach the 95 targets. So there could be at the national level, they are arranging something, monitoring and indicators. So at the local level, the hospital settings, the sexual health physicians work closely with the other doctors to improve the setup.
I'm glad to hear that. Yes, thank you very much. So from Sri Lanka, I would like to travel to the new country. which country are welcoming us? I'm go coming back again. Okay, it seems like neighborhood Pakistan welcoming us to landing. Yes, Dr. Anissa, you have any comments?
Yes,
please.
I just want to share a few things. In Pakistan, there is no mobile phone app currently at the moment for HIV patients. So recently I was part of a research where we were focusing on two things. The major issue was drug compliance for HIV patients. And the other thing is that when the patients, when the common people, they get exposed to HIV, they do not get tested just because of the confidentiality and privacy issues. So we are thinking to launch a mobile phone app which has features where certain risk factors will be mentioned. And if someone has those risk factors and he meets the threshold, he should be identified which screening center he should visit. So in that case, I think stigma and discrimination can be reduced in that class. Regarding the other case where already registered patients were there, they introduced that mobile phone app, and then they analyzed the situation by root cause analysis, and it came to know that having a smartphone app, it is quite expensive, so people will not afford it. So for that reason, they developed a mobile phone app which can be run with 5 profiles on a single smartphone. So they identified the problem that it is not cost effective, and the local language is required. So after analyzing the thing, they designed the product like this, that it has local languages options, and 5 people can do this on a single mobile phone app. And it has reminders to improve compliance for investigations, for diagnostic tests, for treatment, and to get medicine. Even the medication timings also will be reminded by SMS to the registered patient. So this is what I'm just sharing, the process of quality improvement in which they identified the problem, they are applying it, they designed it, then they applied it. And now with the increased number of visits at the clinics, increased appointments, or increased number of tests, I think they will measure the performance of this project. So this is the practical example.
Thank you, Dr. Nessa. So Chanane, do you have any things to add in?
This the example of the quality improvement process. We try to get the problem, and then try to know the need of the client, and then we use something to solve for them. But as we know from this area, we can use this one. The other area may not use this one properly. It's up to the context as well. So appreciate that, and then try to keep it on the quality improvement process. So maybe we can get the best practice all the time. Okay. Okay, appreciate that.
Yes. So for me, it's like try to get people to early diagnosis and then early treatment as soon as possible. The next challenge is how to retain them in the for viral supplies, for better treatment. So going up to the better quality of life, that is the next challenge. But I guess that you may be already on the process of that. But start with that. Okay. Thank you, Dr. Anissa. So, and the other people from other countries? Yes, Gigi, go ahead.
So I'm going to leave the question in the chat box, so I will read it. How do you plan financial support in your project design?
Yes, this is another.
I leave this question to Dr. Niwat.
I'm sorry. Yes, because Angogo is not working in the hospital, right? So he asking how to improve, access to the financial support. So yes, Anessa, do you have any idea from Pakistan? Any experience when you try?
You can get financial support by presenting the data, the severity of the issue, and then the data. If your data is convincing, then definitely you will get financial support. Otherwise, you will not get.
Okay, good comment. First one is you need a good evidence, at least data, perfect one to show, to encourage, or to show other people that it's a good project. Yes. Any other idea from other countries? When you improve your qualities of services in your hospitals, and you need to sustain that, how can you improve your financial support? Seems like okay.
Dr. Niwat, I mean, okay, because because I have to out of this room because I have to solve our country's problem in the pregnancy. I mean, vaccination in pregnant women.
Oh, wow. Okay, understand
for
that.
the Department of Health.
Yes,
and
yes,
because the COVID infection in Thailand just very problematic right now, and my pregnant woman is very very high risk there.
Yes,
so I
yes.
need to share the mhm.
Okay, thank you. Anyway,
okay.
Yes, I understand that. I think the other colleagues, other participants also understand the emergent situation of COVID-19 transmission, and we try to control and prevent that in Thailand right now. So Dr. Chanane might need to leave the room to do some kind of practice. So it's okay. Dr. Chanane, thank you very much for your support in this kind of urgence, and we do hope that if we have any kind of questions, right, we can email you and send you for consultation. Yes.
Okay, I welcome. You're welcome.
Okay, if you need to leave, you can leave, Dr. Chanane, and then okay, you leave right now. Okay,
and have you hope all of you are safe, been safe stay, and I mean safe everybody allow you. Okay, see you when we can make it in the face-to-face conference in the future. Okay, สวัสดีครับ
Thank you, Dr. Chanane. Thank you. Stay safe. Okay, coming back into our room again. So, do you have any? We still have time, 30 minutes for discussion and sharings about your QI process and related to S&D activities. So, we heard some example and experience from Sri Lanka and Pakistan already. So I still would like to move to another country. So anyway, any country would like to volunteer to share? We can move around from Asia to South Africa. Only one country here. Dr. Albert, you have any story to share? Did you do quality improvement in your countries, in your hospitals? Please.
Okay. Thank you very much for this opportunity. Maybe something, one thing to share in my country.
Yes.
Okay. When we there was a survey that was done on looking the root causes of loss of follow-up for HIV patients.
Good.
And one of the reasons which was placed for most of the patients was there was a labeling. The institution environment was not conducive for them to go and take the drugs. So the institution environment was not conducive. There is a separate building for each hospital with a label of HIV or CTC, whatever. So for whoever who is entering that building, that means he or she is a HIV patient. Okay, so the solutions with that problem was first to give much more time for drug refill. Like for those stable patients, they are given according to a new guideline of HIV in our country. They are given drugs for even 3 or 4 or even 6 months. If there is no need for doctor consultation. The other thing is they are given a code number, like a number, identity number, for them to get the service in every center or in every health facility they go, unlike the previous experience where they have to get the drugs in a specific center, in the registered center. And of course, there is ongoing debate currently on whether we need to still label the building for HIV patients, or there are needs to do some other approach. So this is an experience that I can share to my country. Thank you very much.
Thank you, Dr. Albert. Before I forget, the question of Ongogo, we might come back again on Module 9 on the next week. Module 9 for the first day of the next week, yes, about the programming and the financial support. But from what Dr. Alberts mentioned, lead me to another things that I'm thinking about. So can I do a kind of rapid surveys from here, from all the participants, from what the story that Dr. Albert just mentioned? I mean, I will ask the question and ask you to use the tools from the Zoom. You can see the Zoom, they have a reaction, right? And the reaction tab is the raise hand that you use for using when we would like to ask the question. So I will ask all of you to use this tool, the raise hand. Means try to understand the context in your country. That in your country, the way that you manage the building or the clinic for HIV/AIDS client or patients, for those countries who have a separate building, separate clinic, I will ask you to raise your hand. Okay. I'm not sure whether you understand me or not, but because when Dr. Vino said that in her country, there are some things that manages. So and Dr. Albert, so I will ask all of you, from Timor-Leste, from Tanzania, from Thailand, from Laos, from Cambodia, from Myanmar, that if in your country managing the ARV clinic separate from the other building, from the other clinic, please raise your hand. Okay, there are two right now. No, the other seems like nothing. Okay. Yeah. Wow, I'm just interesting. I didn't see all of that. I'm not sure whether you understand my question or not, but okay. So for me, it seems like there are two countries, Sri Lanka and Tanzania, that the way that you provide services for people who are living with HIV and AIDS is providing in a separate area, right? Okay, thank you. So that's why Dr. Albert mentioned about labeling or something like that, you try to solve the problem that because people who enter into that area, it seems like they may be labeled like people who are living with HIV and AIDS. So from Timor-Leste, the way that you organize ARV clinic, can you tell us about detail a little bit about your context, country context? Dr. Mark?
Dr. Newett, okay, hello.
Yeah, sorry,
okay.
I'm not medical doctor. You can, Dr. Chanane is forget about that. So you can call me Newett, it's okay. Thank you, Dr. Mark.
Okay, Mr. Newett. Okay.
Yes,
so actually today I joined this presentation today for this training is late because I have internet problem. I just rejoined in the very last part, so I'm not accompanying all. But in our country in Timor-Leste, I just see, I just saw in the last part of the presentation, in our country, we have like for the registration we have a registration, electronic registration for all of patients. We have it's all of health facility, especially from the national until the sub-district level. Always have electronic data and all its registration by electronic. Well, we still have a problem gaps like internet access in lack of internet accessibility and so many another problem. And then, but in the separation of wards of our patients in our, I think in mostly in health facility, most in district and sub-district, they do not have, we do not have like a separation for like a specific word for that, but indeed we have counselor for HIV counselor for HIV program in all of health facility, especially for those who have treatment for ARV treatment. But even until now, the health facility that have a very low, it depends of case. If have a low case, no, even some this sub-district level do not have the counselor yet. And then and the other problem is patient do not want to come. Maybe they do not want to their identity to be known, or maybe it's like so it's that's also give impact like for the tracing problem. We lost the lost patient, but yeah, I think this lecture is very important. It's very important for us. But I'm not sure if we use application. We also need to see if all facilities complete like to support the access for internet. If many people do not use the smartphone to install the apps. That's why we use electronic registration, but it's still some app, not all use the app because due to so many gaps that we're still facing until now. I think that's all. Kap kun kap.
Good. Where did you learn Kap kun kap from?
I have some friends study in Mahidol University, and they teach me that.
Okay. Welcoming you next time to Mahidol. Okay, thank you.
Amen.
Okay. So maybe there are different contexts from my understanding that lower number of HIV cases. So that's why in Timor-Leste are arranging that there are no separate clinic as needed. But in Thailand, we also, because I'm raising this question because in Thailand, when we do stigma and reduction program, and discrimination program, the question was raised by many hospitals in Thailand, whether when we separate the clinic, HIV clinic from the other building or other separate clinics, will we consider this is a stigma and discrimination or not? So some staff of the clinic, the head of the clinic, try to reduce the stigmatized by changing the name of the clinic to, it's more like creating hope, like they said, New Sky Clinic, something like that, New Hope Clinics, at least to not to labeling the HIV clinic in front of the door of the clinic, something like that. So they think that this will be another way to reduce discriminations. Some hospital they used to separate the clinic, but right now they move all of the HIV/AIDS clients to the same building of the chronic diseases. So this is the way that they arrange. So we have at least two models right now. Some hospitals still, do separate clinic department, but changing the title of the clinics to be more softly. and then the other hospital, they move all the clients to receive HIV services with the other chronic disease in the same building. So I don't have the answer that is this considered as stigma discrimination or not. It's depend on the context, and you need, at least, Dr. Chanane mentioned about listening to the voice of the clients. What do you think about this? I would like to move to another country. That we may not have the answer right now, but I will move to another country to see whether do you have any reaction after Dr. Chanane presentation. Can we move to Cambodia? Cambodia, I can see two participants here, Koso, and I can't pronounce your name, Selim. Do you have any ideas? Yes.
So we stand on the same question, right?
Yes. If you would like to respond to my questions, yes, please.
Okay, I want to share some related to the what is your question? Your question mentioned already. Actually, in Cambodia, is ART clinic is included in the referral hospital in the province. Actually, we have another clinic that's called a family clinic that they provide this HIV service to the people living HIV, and also key population like EW, independent worker, transgender, and male who have sex with men as well. And we get the case of key population refer from the NGO partner that they are get test from the OW audit worker and refer to the family health clinic to get another service like HIV service or confirmed service and STI service and family planning as well. So actually, in the context of Cambodia, is the ART and family health clinic is included in the referral hospital in the province. According to my experience to supervision with the referral hospital, I observe that the service in the referral hospital included also HIV services have relationship between another department and another service as well. Okay, thank you.
Okay, thank you very much. So we have different contexts, right? So I think since we start from 10 and it's almost 2 hours right now, and I think we need like a kind of 15 minutes break. Is it okay, Gigi?
Yes, but I saw Dr. Albert is raised his hand for a long time. Maybe he will have a great idea before we take a break.
Okay, I'm not sure whether Dr. Albert raised his hand or he forget to lower his hand. Dr. Albert, before we take a short break, do you have anything?
No, thank you. I forget to lower the hand.
Yes, yes. Okay, before we take a break, do you have any things to say? If nothing to say, we take a break. How many minutes, Gigi's?
10, Piniwat, please.
10, okay. 10 minutes only, right?
Yes.
Take a quick break. Thank you very much, and we'll come back again in 10 minutes. Thank you, colleagues.
Thank you. Okay, welcome back, everyone.
Yes.
Welcome back, Mr. Niwat.
Yes, Dr. Niwat.
Dr. Niwat, okay.
It's too late for me to go back to the school.
Okay, I think everyone is ready for the next session, right?
How do we know that everyone is coming back? So for those who already come back, please give your heart to the new speaker. Can you see that in my? Yeah. Okay, Cambodia. Yes. Thank you. Okay, Cambodia already in. So for those who just coming, give your heart to our new speaker. Yes, from Thailand. So I didn't see. Yes. Okay, from support team from Thailand.
Thank you.
Before we maybe we take a little bit wait, yeah, because of they may need to go. They may do something like a reduced calorie, doing exercise after sitting for an hours. Yeah. Okay.
Oh, welcome back, Dr. Rino. Okay. So maybe we should start now.
Yes, please.
Okay. The next module is module 8.2, hospital experience from Taksin Hospital. This module will be presented by Dr. Supannee Jirajariyavej, the infectious disease specialist from Taksin Hospital. So welcome, Dr. Supannee.
Good afternoon, everybody. Slide, please.
Good afternoon.
Some country are still morning.
I would like to present about the HIV and sexual transmitted infection, 42 ending AIDS. Next slide, please. The content outlines include the background of the hospital in Bangkok. Next is the getting to 3.0, include the death, new infection, and discrimination, and HIV quality improvement programs, including the conceptual frameworks and HIV quality improvement activities. The last one is the stigma and discrimination reductions activities. Next slide, please. This slide shows the Bangkok as a grant. Our population is about 5.68 million, and the documented migrants about 150,000 people. The Bangkok has the 50 districts and has the 139 hospitals, including the 95 private hospitals and 45 public and state enterprise hospitals and health facilities. It has the 19 hospitals and health facilities under MOPH, Administration of Justice, Ministry of Defense, and 10 hospitals under the BMA that covers 1/5 of the people living with HIV in Bangkok. And the Bangkok has more than 100 health centers and medical centers to refer the complicated case to the Bangkok Metropolitan Hospital, and more than 4,000 clinics. Next slide, please. The Taksin Hospital is under the Bangkok Metropolitan Administration. We have the 10 hospitals around Bangkok. So next slide. And the Taksin is the name of the King Taksin. Taksin Hospital is a tertiary hospital, cover the 473 beds. We cover patients 224,100 persons. The population in responsibility include the 30-bus stream, about 166,000 people. The other is social securities, about 7,000 people, and the other is the foreign workers, about 30,000 people. Taksin Hospital intend to ending AIDS in zero death, new case, and discrimination. And we receive certified from the disease-specific certification. It includes the measurement of the HA accreditation to cover the voluntary covering testing, STI and HIV, by follow the standard guideline of HIV and STI treatment. The next slide, please. This slide shows that in Thailand, we have the hospital accreditations, and now in some disease, moving to the disease-specific certification is certified for the basis excellent. The disease-specific certification is the accreditations of the Thailand that focus on the disease specific. It's including the process management, critical outcome, quality management, system thinking, core value driven, consumer quality improvement as a Dr. Chanane mentioned. So if you achieve 95, 95, 95, it means you can get the goal ending age. But if you can meet that, it means that you can get the goal. The disease-specific certification and patient care process for quality improvement. It means the concept of the purpose, process, and performance, what you do. And you use the data analysis for improvement, the quality. And it's at the part of spiritual in the DSC. And we follow the care process of ending age by 30 care process. We assess the case from access to empowerment. The improvement, the quality by the disease-specific certification, it means that you set up the system and capacity building. The system, when you use this concept, is more easier, convenient, comfortable, and safety. And the capacity building for the personnel and patient understand empathy, self-awareness, and spiritual. So it's make sure that patient and personnel with satisfaction and safety. And then you can reduce part of the stigma and discrimination. This is a concept of HIV patient care component. In the patient that no HIV status will receive to care, treatment, and safety. And you will set up the reader, provide the process planning, monitoring, and evaluation. So in the case that negative, will stay negative. In the case positive, will receive the assess the obstetric infection, receive the ARV, and include the part of the PMTCT, pregnant woman and child. And we will have the support team like the pharmacists, laboratories, IT, ENV, IC, risk management, or human resource. This is a framework of HIV and STI quality improvement by the concept of disease-specific certification. We use the strategy of which we could test, treat, and retain, and did a supporting team, as I mentioned. So after we follow the disease-specific certification concept, it's the first time for us to provide a vision and mission for quality of the HIV and STI by advanced and professional service. Our mission is service delivery approach, health promotion, disease control and prevention, from diagnosis and treatment rehabilitation, and networking and referral system from the BMA and health center, and high competency service. After we have the vision and mission, then we announce our policy to the leader team and the operating team by the strategy of which we could in the keep up for test, and in positive case for treat and retain, or in case that negative testing, we will prevent. And our goal is to reach to 95%, and don't let the stigma and discrimination is the root of the problem that may affect patients to lose the job in the future. We have the strategic plan for quality HIV/STI by advanced and professional service. We have the 5 items and has the KPI for monitoring. Our concept is we care for all positive or negative tests. Our purpose, the first is increase access to care. The KPI is percentage of HIV screening among target population, percentage of high-risk group have received VCT, and percentage new case of HIV received ART within 7 days. Is a part of which we could test. The second item is no HIV status. The KPI is percentage of high-risk group no HIV status. The percentage of high-risk group still in stay negative. And VCT, we provide the VCT condom, PrEP, and regular blood screening is the part of retain. The third item is purpose for improved care and treatment. The treatments aim to reduce the loss to follow up to death and viral suppress. And the next is reduce stigma and discrimination for aim to normalize HIV. So if you can deal with the stigma and discrimination and normalize the HIV patient and staff, you can retain in the system. The last one is improve support system for certification of smart information. The next slide, please. This is a patient care quality development by RRTTR strategy. Which we want to reach by increased assessment of the key pop, and we win the system by open the MSM clinic for reach the patients and open the STI and PrEP service in the extraordinary time. Recruit, we tracking the system by the IT to the key off for early testing. We provide the same day results and expand the test for every day and reduce the waiting time, synchronize the data links and communication lab alert. Next, about the early treatment, early access to ARV, we moving to same days ART by the fast track lab alert and develop tracking system to follow up appointment for reduce the loss to follow up and develop care for infected people with cold disease. So in the patient with the comorbid like the metabolic syndrome can provide treatment in the ARV clinic, following the system. Next, about the retain, aim for retain the HIV patient and in the high risk that's still negative. We cooperation and adhere launch in ARV treatments and assessment and follow up continuous treatment. And we set up the differentiated care for provide the medication about 6 months and stay negative tracking system. The next slide, please. This slide shows the improvement program from 2003 to 2019. We have the HIP core for improvement the coverage of screening now more than 80% coverage. And we have the sender service for the vertical child transmission for the family for ARV follow-up. And we have the problem about coverage of VCT pre and post test. So we divide to the 2 teams for cover OPD and IPD VCT. And next is the prevention with positive program. And next is PMTCT that provide the vertical transmission and couple housing testing. Now coverage is more than 80%. And in the key pop MSM, we open the MSM clinic in extraordinary times. And the last one is we open the STI clinic and stay negative clinic and the same day ART. Next slide, please. These are achievements as a result of disease risk certification for HIV. In 2000 years, the coverage is 100 for screening in key pop and 96% for known the status and receive the ART. And the suppress is 92, but it's had the barrier about the COVID situation. So we lost some appointment, but the patient still take the ART. Next slide, please. The median CD4 is only 200, but it's a challenge for us that we hope to more uprise. But due to we are the tertiary hospital that has the complicated care, so it's challenge for us to recruit the early case. Next slide. This is a part of the couple counseling. Do you find? What do you see in this picture? What is different? Can you find the 6 among the 9 number? This slide it shows the challenge for us to find out the discordant couple. In the pregnant women, we found the discordant couple. So the OBGYN doctor provide the couple counseling in the HIV, hepatitis B, and syphilis, and the coverage is 87%. And we found the high risk pregnant for HIV infected reducing from 85% to 8%. Next slide, please. And this is the number of the partner for screen. The HIV is the HIV screening now is 100% for the pregnant, and other is the syphilis and hepatitis B. We found the discordant couple now more than 100 couple, and we provide the early PrEP or provide the early ARV. So the vertical transmission is 0, and we expand the service from the ANC to the postpartum unit. So in case that not receive the couple counseling, will receive the couple counseling in the postpartum unit, and coverage is 22%. Next slide, please. This is the moving of the STI and PrEP service from the NC couple counseling extend to the postpartum department, and then provide the couple counseling extend to the hepatitis B and syphilis couple counseling in the ANC and the postpartum, and open the RAP clinic and STI clinic, and open the STNet clinic to cross follow up the high risk group, and provide the PrEPs and STI, and open the STI clinic. And now we screening the HIV test and syphilis test in STI clinics are more than 80% by the coverage between the in the medical organization and use the IT to pop up alert and feedback the data. And this slide show that you see that we have the discordant couple in the syphilis, and the discordant couple in the hepatitis B. So it's a challenge for us to couple counseling in the HIV, syphilis, and hepatitis B. And now we can link it to care. And so as we mentioned that we will care for all, include the HIV positive and negative for STNet. So we provide the PrEP STNet clinic and flag the key pop in STI clinic. And next slide, please. About the last zero of the stigma and discrimination. As you know, that stigma is the negative belief or negative attitude, and discrimination is mean the action or behavior from the attitude. So next slide. So in the 2018, in Taksin Hospital provide the S&E implementation. We set up we receive the training by the center, and we have the trainer for trainees programs, and we have the 3 times for surveys. We have a corporate staff for receive training 1,300 person, and all disciplinary team join together for the training, for the training, and we are commitment to use the strategy of RRTTR for getting to zero in Taksin Hospital. Next slide, please. The purpose of the reduce S&E in HIV, the process using principle by learning practice 3+4. Participation, treatment decision, and provide quality service, standardizing patient rights. Our KPI, we measurement the outcome. M, if the patients reduce the self-stigma and reduce the discrimination by the organization, so the patient will be retained in the system. So our KPI is the new rate of access to ARV in 7 days, above than 95%. Success rate of people receiving antiretroviral therapy is above 95%. Missing appointment rate below 2%, and no complaints were found. This slide shows the quality improvement for reduced S&E. The level of organization in 2018, the development baseline situation, monitoring progress evaluation, develop the capacity to educate personnel with participatory, adjust the environment, adjust the service system. normalized HIV blood testing personnel at the annual health examination. The coverage are now more than 5,000 personnel. And potential development for knowledge sharing with personnel, organizing exchanges, patient journey map, thinkings and feeling in the third quarter action plan, analyze situation in the March 2019. The 11 individual understand rights, participate in self-care plannings and empowerment programs, and the level of monitoring and evaluation, develop and surveillance system by ICW and leaders, and risk register HIV STI risk reporting system. The next slide, please. These are clinical outcome for the KPI. Now, the coverage HIV patient receive ARV within same days is more than 85%, and receive within 7 days is more than 100%. In case without obstetric infection. Next slide, please. And the lot to flap is declined 0.98. Next slide, please. And stigma style and solution. After the training, we found the problems about the division of specific clinical zone, the use of pronoun, use of equipment more than necessary, or the order of keeping the queue and the handover. Next slide, please. And the labeling or ARV specific clinics, separation of breastfeeding from bottle feeding, separation of patient equipment, or lacking of procedure for the last queue. Next slide, please. And service behavior and negative attitude, promote sterilization of HIV infected mothers, criticize patients for missed appointments, and the last is history screening in the public area. So we write the driver diagram, aim for, it's one example to reduce overprotection 50% within 3 months by the education, training, education, and KM COPS and sharing best practice by group learning, storytelling, and car study. And the second is driven by the policy, really by the guideline and training, education, KM COPS, and sharing best practice. The last one driven by the attitude. We increase the positive and decrease negative by use the storytelling. Next, and we use the QQI as a tool to assess risk of HIV infection. The quantities HIV is in human only, so HIV is in some secretion in the body of the people, but not all. It depends on the quantity. Next is the quality. HIV must be to sufficient quality. HIV cannot live outside the human body. The last one is the route of transmission. HIV from the body through the 4 parts of water, bus, semen, vagina, water, and breast milk. But not in the saliva, tear, or milk, cut, or sweat, or feces. So it's a tool for assess the risk. Next slide, please. And we promote the 1 unit for 1 project, like the project of the prioritize the queues of dental surgery service. The second, like the stop dividing the deliver zone by adjust the patient management system. The third project is use the use of precaution, ICWN as the mainstay. The next is the equipment management, medical instrument by use the universal precaution principle. Next slide, please. The role and duty of ICWN is to promote the universal precaution, special precaution, and to engage in the service tracks that have been stigma and discrimination of agency and modify with CQI. monitoring of S&D and reporting of risk when an event occur, build learning to reduce stigma and discrimination. Due to we have the infection control ward nurse all the ward, we have nearly 90 person. And this slide show that after the organization learned about the S&D, so it's no separate zone for the HIV patients. Okay, and next slide. Okay, and no queue, no separate queue for the HIV in the dental exam or in the operating room. Keep the standard cleaning after the finish each case, but not special cleaning in HIV. So the stigma aim to reduce stigma to prevent loss to follow up, because sometimes due to stigma is the attitude or belief. So sometimes it's hard to clear it, but aim to handle the stigma or stigma is to prevent the loss. And the discrimination aim to receive the standards of care. Next slide, please. Okay, next slide, please. Okay, next slide, please. Next slide, please. Next slide. Okay. So we use the motto start with why, but why in yourself, why in the personnel, because normally we will ask why the patient, why don't you take the medicine, why don't you not to follow up, but now we change the mind to that why in yourself, in the personnel, to how to cope with the patient, not to follow up, like following the system for the cost to follow up, and deep listening the patient. So when you why yourself, you will change your mind, and you will learn or sharing together for improve the way to solve the problem. Okay, next slide. And we have the mini activities for the personnel by the question: if someone we love is infected with HIV, we want to tell him that, and the personnel will write the words or some sentence to show the attitude for that, and then we clear in some personnel that are not clear for the stigma and discrimination concept. Okay, next slide, please. Okay, the next slide, please. Okay. In organizations, hope for the stigma and discrimination implementation, that when we have the personnel who infected with HIV can open to receive treatment with our organization, but it's a challenge because now it's not all the personnel that can open. Okay, next slide, please. Okay, and this is S&D monitoring that trends of the fear of HIV infection is reduced, or negative attitudes is reduced, but now it's about 50% is the challenge to moving, and stigma avoidance behavior now is 18%, and observed discrimination toward HIV infected patients is 20%, and observe the health care working unwilling to care about 12%. The last one, uncomfortable working with health staff living with HIV is 15%. The next slide is the S&D monitoring in people living composite indicator. In the experience discrimination is due to 3%, and self-stigma 16%, and unauthorized discord of HIV status is 1%, and discrimination related to sexual and reproductive health 2%. The last slide. Our key success factor, the organization commitment to HIV and STI development. We have the lead team together analyze the context and determine the vision, issue policy that are easy to operate, and survive and monitoring the work to achieve the plan in the hospital period. We have the support team understand and know their role in helping to drive the job, the disease-specific certification board, communication in the organization, and coordination in relevant areas using strategies, publicity and pride in the work, enable each division to have its own indicator that are consistent with the work. Okay, that's all of my presentation.
Okay, thank you, Dr. Supannee, for your presentation. Excellent story. Then I'll give like a time turn to the colleagues. If you would like to have questions, ask questions or opinions or comments first. Yes, please. Go ahead. Are there any questions? There's a lot of information, but I think for me, my impression is go into the last sessions that Dr. Supannee mentioned about changing. For me, for my interpretation, it's about changing your mindset, rather than look, at the problem and blame or think that the problem has come from the patients. But she said that better look back, go or dig deep into your services and your team, try to find to better improve the quality of the services. I think this is the key things. And the other thing, the second one is the changing the mindset is, I remember that when I do the training, stigma and discrimination reduction training, we used one question, said that for our trainee to share and talk. My question is about if someday you are HIV positive, if you yourself HIV positive, how would you like to tell or talk to whom? Who would you like to tell or talk to? But Dr. Supannee changed a bit of the question. I think I'm really impressed. Seems like she said that if someone you love acquiring HIV, what would you like to tell them? But both question is the same strategy for me. It's kind of bring down, the war between you and HIV patients to have the same, get close together, look at them like a human. So not look at them like a patient or something like that. So this is a good mindset for me to do quality improvement to reduce S&D. So this is my in place. So for you, what about you? I see Anessa speaking something. You forget to turn on microphone, or you speaking with your... No? Okay, thank you. Are there any questions, comments? Many of you mentioned about fear, right? Since from the first day of the training, one of the key driver in your hospital is about fear of acquiring HIV, from providing care to the clients, right? So the fear, drive to stigma and discrimination. So if you have some experience to talk, to share, please. Dr. Mark, you raise your hand from Timor-Leste, please.
Okay, hello, Dr. Supannee, Sawadee. I think, like Sir say, Mr. Niwat say, if for example, if I have if what Mr. Niwat says is true, we need to break down the wall. For example, if I have some positive, if I am an HIV patient, I think as a human, and mostly people that with very few knowledge, they will feel like a fear. And I think the first thing we need to do, like we need to break down the wall. We need to find someone who we trust. Because we trust. So I think as a health professional, it's very good and very important to build a trust. Like we consider them, like you said, we consider them not as a patient, because when you catch a patient, maybe in a very few percentage they will feel like different, like you are creating barrier. You are here, I am here. So let's make like a good environment, build a good environment by building trust. Like you and me, we look them as the like as a human, as a people. Or maybe we can try something better, like as a friend, because when they come, they will seek for trust. Because patient will say, if I trust you or not. Our job is how to build the trust and how to create a good environment, make them comfortable, trust and comfortable. So, and they will cooperate. They will cooperate with us. So I think it's like you say, no wall. Don't see people as a patients or as anything like you HIV. I'm not HIV. That's not good. I think we need to see us like same people. We are with the same right. And maybe we can build like a friend. Actually, I want to share also. I have one friend with HIV, but when I talk with him, it's talk normally, like a normal people, friend to friend. And what they told me like they are afraid, like they want to come to health facility, only they are afraid of. I say, what you afraid of? What kind of afraid you have? So I say, don't be afraid. You are same like me. You are same like all. You are my friend. You are still the same like before. We are friends. So I think building trust, broke the wall and create the environment that we are the same, and to make them comfortable. So I think by that is better. I think, and Dr. Supannee, your presentation is very good. Only very big. I will try to read one by one. Okay. Thank you.
Sorry for.
Thank you, Dr. Mark. Then any other response? We flying from, taking off from Timor-Leste, and we were landing on which country? Okay, Pakistan.
Yes. In my country, basically HIV patients are managed in few tertiary care hospitals and not the routine hospitals. Even the outpatient clinics are based there. So people have to travel a lot for that, for taking appointment, diagnostic tests and medication. For me, I think the stigma also comes from this thing that very few doctors are treating this. Even in my hospital, which is the largest hospital of the country, there are very few people who have been dedicated to that. Even the medicine residents, they are not exposed to HIV patients routinely. So there's a specific team for that, for management. And I think fear among them is because of less clinical awareness, less management. Previously, when I was a resident in medicine, I also had a fear to manage such patients. But when I was exposed to them and I started treating them, and I was made part of that team, then the fear gradually reduced. So for me, I think segregating all the things inside the hospital, even, that is a wrong policy, and we need to work out on it. And for that, definitely rotational trainings of different doctors, healthcare workers, staff, that can be managed in the tertiary care hospitals and the basic health units and the secondary care levels.
Good, thank you. Thank you. Well, but from Dr. Supannee's examples, when she mentioned about you have to create a safe spaces between yourself, and then your customer, your clients. But anyway, when the Taksin Hospital teams learning about stigma and discrimination, I think from 14 examples of the form of stigma and discrimination that Dr. Supannee mentioned, is many of them related to fears. So I think from Dr. Supannee's story, she said that the way that the team tackled to the fears of acquiring HIV while providing care for the client is, her purpose is, she proposed that 50% reduction of over UP, right? Overprotection. So this is her goal. But the way that she tackled in many back, dig back into her team and services. She take a look at delivery room, dental clinic, operation room, something like that, And then the way that she tackle is tackle on knowledges, strengthening about the way that she uses QQR, quality, quantity, and route of transmission to make sure of better knowledge, understanding about transmission. And then she strengthening on the standard equipment, right? Some of her staff, her team might be worried about lower standard of some equipment that we learned. That's why some people use double groove because they are not sure that whether use one groove is good enough. They worry or questioning about quality of the groove. And the other thing is, she bring up the attitude, try to create a better or positive attitude about that. So I think this is a kind of, and then take a review of the procedures, So this kind of thing and moving forward in progress about, reduce of stigma and discrimination. But Taksin context is not quite easy because it was in Bangkok areas. That's a lot of, if you remember in the early beginning that she mentioned about many of her client or customer are from neighboring country. They are migrant workers. Some are documented, some are undocumented. So it's mean like the problem are more complicated than we in general. So, but this is the way that Taksin trying to learn and manage, go back, dig deep into their services and improve that. I think this is one of the other things. So we still have like 15 minutes if you would like to share your story or ask question or clarification for Dr. Supannee. Yes, please.
There's a question from Anuman on the chat box.
Yes, can you read it?
I have two questions. First is stigma caused by comorbid disease, especially tuberculosis. How to provide service without stigma and discrimination? Is it my question? Is the first.
Okay. Yes.
You mentioned about the co-infection with the tuberculosis, right?
Yes.
With which HIV or only the tuberculosis?
Yes.
With HIV.
With HIV.
We didn't have the problem about the stigma of the tuberculosis. But we just communicate that it's just like the pneumonia. That you will keep the patient will keep yourself safe, and the other will keep the other safe, like that. So we separate the place for good ventilation for you, like that. So we will mention the positive word for better for the patient to live from the other. Because it's have the good ventilation outside the clinic, like that. And the other patients will understand. Will understand this concept.
Thank you, Dr. Supannee. My question, another question. Why today's COVID in Thailand will have more and more patients, and COVID-19 is the first problem to service healthcare provider or have a lot of work to concern about COVID-19. Will it have effect to service with for people who living with HIV in Taksin Hospital?
You mean the impact of the COVID-19 the service? Due to we have the differentiated care for the HIV patient, so we classify in the three group of the patients. But the first group is the patients be diagnosis in the first year, we will make appointment not more than 3 months. And the second group is the patient in the second year that has a good viral suppressed. We make appointment not more than 4 months. 4 months for each visit, right? And the last group in the third year of the treatment and have good viral suppressed, we will provide 6 months for follow-up. So mostly of the case, more than 70% of the case is in the 3 group that we provide the multi-month drug. And we have the send the ARV by the mail. So someone meet the doctor only 1 time per year for the blood check. So it's not disturbed in the COVID situation. But only the blood check regularly. So the last 95 in the viral test coverage is quite low in this year because it's meet the time for blood check regularly. And I think that the COVID situation is a challenge for adapt to the concept of the S&D in HIV. I think it's the same. I think if we can learn from the COVID situation that why many patients brave to come out to screening themselves for early diagnosis of COVID, but HIV is not the same. But if we can make the patient concerned like the COVID, when you have the risk, you open mind to screen for early diagnosis, for early treatment. Yeah, I think. And about the S&D is the same, COVID and the HIV, I think it's the same. Because it has many S&D in the COVID patients. But if we learn from this situation, we will adapt to the HIV for early diagnosis and treatment.
Yes, thank you, Dr. Supannee. I think that there are also some comments from Pakistan and Timor-Leste about providing HIV services during COVID-19 pandemics. I think we found, like Umanat mentioned, that we found challenges in this situation, that we try to reduce number of patients or clients to go to the hospital and reduce the hours of the services that they use, or limited number of people to go to the hospitals. So that's why they mentioned about any challenges. But the way that Taksin mentioned is just only one component of providing care for people who are still on treatment. Like she differentiate groups of HIV/AIDS clients into 3 groups and providing a number of drugs or ARV to them for longer time, and then try to manage the monitoring system to monitor their health. This is just only one component, but if you see that Taksin also have a kind of prevention method too. So I think it's my impact, but if we have more time, we may see that how Dr. Supannee or her team try to retain, a person who have high risk of acquiring HIV, like a key population, into staying negative. How she can manage? How can she manage the way that they get access to necessary tools like condoms or PrEP or things like that? Why they cannot go to hello kids from Pakistan, hello. It's family time, sorry. Well, anyway, we have limited of time right now, and Taksin is in Bangkok area. It was hit hard by COVID-19 too. So in this last 5 minutes, I will give a chance to persons that who think that they really need to ask the question or say something to Dr. Supannee for the last 5 minutes. Are there any colleagues? Yes, Dr. Mark from Timor-Leste.
Dr. Supannee, I want to ask something. Maybe you can explain. For example, we now know that we are now in pandemic of COVID pandemic. Maybe you can share your experience. For example, if they've actually I never attend this patient like this, but if you can share, if you have an expert or any friend have this experience, I want to ask if some patient come with symptoms of with flu, with those things, and then but this patient have like a mental disorder or mental problem, but they also have HIV. Maybe you can share your experience, how the best way you treat in maybe in a Thailand experience, how to treat patient with HIV mental disorder. In the same case, he or she I don't have symptoms like flu symptoms. So how you provide the care for them? Thank you.
Sorry, I'm not clear. You mentioned that the first diagnosis of the patients of HIV.
No,
right?
For example, it's like a case. I just want to know about your experience in Thailand experience, how you treat a patient with HIV and also with mental disorder or mental problem. Yeah, and then in the same case, they also, like now, we are now in COVID pandemic and come also with the symptoms flu, how you treat, and then to prevent the stigma and discrimination also, how your experience.
Questions, lots of factors, HIV, mental disorder, and COVID. How you manage with that kind of situation?
You mean the HIV with the mental disorder, right?
Yes. Suppose that one client enter to your hospital. They are HIV positive and have mental disorder, and they have signs of COVID-19 too.
Oh, together.
So how you manage? How you plan to do? Yes.
Okay, I know. In case we set the priority, right? So the COVID-19 is the first, right? So we treat the COVID-19 and quarantine first, right? And then we assess the state of HIV. That for after we control the COVID and no problem about the ARV treatment, then we provide, because we screen HIV all the case with the COVID-19, and we found a new case. And we connect to the laboratory to provide the screen for the obstetric infection, like the blood check of the cryptococcal antigen or CD4 in some case that we not sure for the prophylaxis obstetric infection. So we provide the early ART after the complete favipiravir. And we have the case due to Taksin Hospital is near the Somdet Jalphaya Hospital, which the hospital about the mental disease. And we have many cases of the HIV infections in the Somdet Jalphaya Hospital. That some case is the old case, some case a new case. So we provide to screening all the cases that come in the hospital. Now we provide the screening HIV test in case that admitted in Taksin Hospital by the word screening of the previous injection, previous of sex, previous of IVDU, right? Because when we assess the risk, someone didn't have the active risk, but in the past, or the partner have the risk. And we found many cases like the aging patients last 5 years ago, but admit with a fast track stroke. After that, 2 years had a full burn of TB. So we commit that all the cases that admit in Taksin Hospital will receive the blood check for HIV for screening. and for early treatment. And this idea we promote to the Somdet Jalapaya Hospital for provide the screening HIV in the mental case.
So Mark, are you fine with that response?
Yeah. It's good. Yeah, it's good because like in here we still have so many gap. Still have like a lack of the it's a new country. We still building in this country, our country. So we still lack of many infrastructure. Maybe we hope, but we slowly but surely we hope maybe if by having also good facilities and more health professionals to support, I think that's very good because if a normal people with HIV is different with a patient with a mental disorder, and it's kind of more difficult. And I think thank you, Dr. Supannee, for your sharing experience.
With three problems like that, maybe we assume that these patients or clients might find or confront with double layer of stigma and discrimination. But the way that you guys are doctors, you prioritize the way to can help them first. Start with COVID, that's the emergencies, right? But for me, if I can add something, like I also found some HIV/AIDS just early diagnosed. He's young and he's learning disabilities. So the other way around is to find someone, if you give them a drug for treatment and you need a kind of family support or someone to get close to them, at least to help them adhere to the drugs because there's some kind of disorder problem, right? Learning disability or mental, something like that might need to be concerned too. So thank you very much for a fruitful sharing and discussion. We run out of time right now. I think we have to close the session. I'm sorry for those who didn't have a chance to talk. But anyway, again, please give a big hand to Dr. Supannee for her presentation, excellent presentation. Thank you very much, Dr. Supannee. Well, have technical support, lots of echo, right? Okay, stay safe, Dr. Supannee, and your team too. Yes. Okay, thank you. Gigi, it's your turn.
Yes, thank you, Dr. Supannee. Thank you, Piniwat. So nice. Already 1 p.m. in Bangkok. But before we leave, we would like to rerun the morning video again. Yang Mi Dong Tawan for someone who might be missing in the morning. And if anyone have a video like this, a video to promote the ending HIV, ending AIDS, or reduce stigma, you can send to me by the itcthaitraining@gmail.com, and we will show it during the break time. So I would like P. Thawachai to share the video again, please.
ขอโทษด้วยนะ เราคงรับคุณเข้าทำงานด้วยไม่ได้ ทำไมล่ะครับ คุณสมบัติของผมก็ตรงตามที่บริษัทกำหนดไว้ไม่ใช่เหรอครับ
นิดก็นึกว่าเราเข้าใจกัน
นัดเข้าใจนะ ว่าเราคบกันได้ แต่งงานกันได้ มีลูกกันได้
แล้วปัญหาของนัดคืออะไรอ่ะ
ปัญหาของนัดคือ ครอบครัวของนัดน่ะเขายังไม่เข้าใจพวกเรา
เหลือคนสุดท้ายแล้วนะอะไรจะกินอะไรเนี่ยทำไมอ่ะ
เอาไปคนละขวดเลย
ขอบคุณค่ะพวกพี่กำลังทำอะไรกันอยู่เหรอคะ
พี่รณรงค์เรื่องเอดส์กันอยู่ค่ะ
แล้วทำไมไม่เห็นมีใครสนใจพวกพี่เลยครับ
มันก็เป็นแบบนี้แหละแต่ว่าพวกพี่ไม่ยอมแพ้หรอกนะ
ให้พวกผมช่วยไหมครับรับรองมีคนสนใจพวกพี่ขึ้นแน่
แม้จะมีบางอย่างแตกต่างจากใครเขาไม่ได้แปลว่าชีวิตเราจะถึงทางตันยังมีดวงตะวันส่องแสงทุกวันเท่าเทียมกันทุกคนยกมือยืดอกกันหน่อยไล่ความเหงาหงอยกันไหมทำตัวเราให้แข็งแรงทั้งกายทั้งใจกันไว้พวกเราหนทางอีกไกลชีวิตยังได้อีกยาวยังมีดวงตะวันทุกเช้าไม่เห็นต้องถอดใจออกไปยืนมองฟ้าไปท้าลมฝนเราก็คงเหมือนกันออกไปเดินตามฝันที่เธอกับฉันเคยฝันกันไว้มีชีวิตก็ยังมีหวังทุกอย่างมันอยู่ที่ใจไม่มีคำว่าทำไม่ได้ถ้าหัวใจยังสู้สยาม
เอดส์รักษาได้จริงเหรอน้อง
จริงครับพี่ยิ่งรู้เร็วรักษาเร็วก็จะไม่ต้องป่วยครับ
HIV มีครอบครัวได้ มีลูกได้
มีลูกได้ แล้วลูกอะคะเดี๋ยวนี้มียากินป้องกันค่ะ ลูกมีโอกาสติดเชื้อไม่ถึง 1%
ผมมีสภาวะเสี่ยงผมควรจะทำอะไรดีเหรอครับ
ผมแนะนำนะครับให้พี่รีบไปตรวจเลือดนะครับ
เด็กแถวบ้านเล่นกันคนทำงานด้วยกันอย่างนี้ก็ไม่เสี่ยงติดเชื้อ
ถ้ามีคนอยากศึกษาข้อมูลเพิ่มเติมเนี่ยให้โทรไปที่1663
อันนี้นะ
ใช่ครับในนี้ก็จะมีรายละเอียดบอกไว้นะครับ
หนทางอีกไกลชีวิตยังได้อีกยาวยังมีดวงตะวันทุกเช้าไม่เห็นต้องถอดใจออกไปยืนมองฟ้าไปท้าลมฝนเราก็คนเหมือนกันออกไปเดินตามฝันที่เธอกับฉันเคยฝันกันไว้มีชีวิตก็ยังมีหวังทุกอย่างมันอยู่ที่ใจไม่มีคำว่าทำไม่ได้ถ้าหัวใจยังสู้สยามไม่มีคำว่าทำไม่ได้ถ้าหัวใจยังสู้สยามแม้จะมีบางอย่างแตกต่างจากใครเขาไม่ได้แปลว่าชีวิตเราจะถึงทางตันยังมีดวงตะวันส่องแสงทุกวันเท่าเทียมกันทุกคน
Yes, okay. Thank you for today and thank you for comment, Dr. Mark. So we will see you tomorrow and please become before 10 a.m. to test your mic and microphone, please. Okay, see you again. Bye.